Hi, everyone. I'm just so honored to be here. Thank you to our wonderful organizers. I've been coming to this conference for a decade, maybe a little over now. Gosh, makes me feel old. But I love it. Every year I look so forward to it. So I'm just so thrilled to be here. I know this is the last talk of the day. I'm keeping you from the bar and snacks. So I'll try to make this exciting. And so we've been talking about fertility preservation all day, and I want to talk about some of the ethical issues that have come up, because it's been really exciting that people have been bringing up ethical issues. So we'll come back to a lot of those. So what we're doing today is we're going to talk about these ethical issues for pediatric patients. I don't have any disclosures except for I'm just so happy to be here, especially after a 12-hour delay yesterday with the snow. I know other people had similar things. Okay, so you're probably familiar with or at least heard of these 4 bioethics principles. Love them or hate them. They're used all the time in medicine. And so I want to give a quick overview of what they are and how they apply here. So we have autonomy, and I have this, which is hopefully working. Yes. Okay, because it's hard for me to stand still sometimes. Which has to do with being self-governing, right? And in pediatric cases, we're looking at the child's developing autonomy and their future autonomy versus their best interest, right? And we recognize that sometimes children, and even adults, don't make the best decisions for themselves. So how do we weigh these two? Beneficence has to do with doing good. And so the whole point of fertility preservation is to do good, is to preserve their potential genetic parenthood, right? Non-maleficence is sort of the flip side of that coin. It's do no harm. And so there are harms if we don't preserve their fertility, but there can be harms to doing this procedure as well, right? There's a whole bunch of justice concerns that we can talk about. One that's been brought up already is access and cost. I'm going to move around, but hopefully not trip on this. Because I was sitting over there earlier today, and I don't want this side of the audience to feel like not loved, you know? So I just want to give some love over here. So access and cost clearly is an issue, and give the camera folks a little run for their money while I move around. Also, when we're looking at FP, fertility preservation, and comparing it to other medical treatments. And what we see is that reproduction is often seen as not real medicine, right? It's often relegated to, oh, that's just reproduction. You're not gonna die if you don't reproduce. But what's important to point out is that so much of medicine today is about quality of life, right? I have seasonal allergies. Ragweed is my nemesis, okay? And I am miserable. Once the ragweed comes out, I'm miserable, right? So the doctor could say, sorry, suck it up, buttercup. But instead, they give me medication, and I'm a much happier person, right? Same thing with fertility preservation. This is a quality of life issue. There's all sorts of quality of life issue things out there, like back pain, erectile dysfunction. I can't speak to that one personally. But, right, these are the sorts of things that are really important and improve our well-being. And so I think it's unfair to say fertility stuff, psh, not medicine. Okay, as we're going to talk about, also justice issues for disadvantaged groups. Okay, so when I was developing this, I was like, oh, this is so cool. I'm going to nerd out on all these ethical principles. And then I thought the audience is going to be bored to tears. So what I decided to do instead is to do a case-based approach. I think that'll be more interesting for all of us, right? Yeah, and some of you are nodding, you're like, oh, thank goodness, dodged a bullet there, right? So I'm going to examine 3 cases here for 3 different pediatric populations. These are composite cases, right? They're not based on any real cases here. And these are based on some of my collaborative projects with wonderful people I see in the audience. And so I didn't wear my normal jacket I often wear when giving talks, which is corduroy with elbow patches, because I wanted to hide the fact that I'm really a philosopher. So, at least by training. So when I'm talking about these cases, if there are any medical errors, that's my fault, okay? Not my wonderful colleagues. I tweak these cases a little bit. And so just, you can point those out to me in the Q&A nicely. But any errors like that are mine. So we're going to talk about some of these cases. Okay, when we're doing ethics, we sometimes use what's called the 4-box method to analyze a case. And this gives us the starting ground here. We need to start with a medical diagnosis. And I'm told I have I do, excellent. What are the actual facts, right? What's going on here medically? What's the prognosis, diagnosis, all that good stuff. And then we need to look at patient preferences. What does the patient want? And this ties back to that principle of autonomy, right? Quality of life, as I mentioned earlier, much of medicine is about quality of life. So we need to look at that And we need to try to address it and hopefully improve their quality of life. And then we have contextual features. And those are sort of the opposite of the medical features. The medical are looking at the scientific facts, but we're not robots, right? We're humans. And so there are all sorts of social factors: religion, race, gender, socioeconomic status, all these sorts of things, law, policy, that play a role in people's decision makings, right? So we need to incorporate that as well so that we recognize that we're real humans with lives, right? Okay, so case one, Oncofertility case. Hopefully I'm not making you too dizzy moving around. Is anyone getting sick? Okay, good. So we have a case here. This is Ben, he's 4 years old. He has a brain tumor with a poor prognosis, okay? So it's a very sad case. His parents want FP, and this means testicular tissue cryopreservation, right? Because he is a minor. Good, some of the scientists and clinicians are nodding. I'm like, I got that right. So we're looking here, what do we do in this case? Who decides? This comes up in pediatric cases, not just in FP, but all pediatric cases, right? And he can't give consent, he's 4 years old, right? He's probably not even sure he can give assent because he's so young, he doesn't have the ability. But obviously we want to involve him to his intellectual maturity. So his parents should make the decision. And I put this word up here, paternalism, and some of you are probably cringing and going, oh my gosh, that's what she means, right? No, the word paternalism is a dirty word sometimes in medicine because there is this whole history of being really paternalistic, right, in a bad way. But when we're talking about parental paternalism, really what we're talking about more is this, right? And I had to have at least one really cute baby picture in here. And so this is a good thing, right? And I can share my personal story about this. When I used to go to my Nana's house, my grandmother's house, she let me eat whatever I wanted, right? I got a cavity at age 5. Thankfully, it was a baby tooth that came out not that much later. But we don't want to trust children to make their own decisions, right? We need parents to come in, and this is what it looks like. In most cases, there may be a few anomalies, but if you let children choose what to have for dinner, they're gonna have ice cream and candy most nights, unless your children are very different than I was as a child. So this is a good thing. Paternalism here protects children, and the origin of the word paternalism has to do with a benevolent father who's looking out for the well-being of his children, right? So I think here we can totally justify paternalism. And this might be obvious to you all, but I want to lay out some of the reasons why we might move forward with FP, just so we're all on the same page. There's this idea of an open future, and that we want to allow children various opportunities. We don't want to close the door on opportunities for them that they might want in the future. And so this is why there is clear legal precedent for giving blood transfusions to Jehovah's Witness children, right? Because we say they may not follow that faith as adults, and so we don't want to close off their future and end their life if they don't believe that later on, okay? So same thing here, we don't want to close off the possibility of genetic parenthood. Some say that foregoing FP is equivalent to sterilization. I think this is not quite right for a couple of reasons. One is intent, right? When parents forego this, they're not being like malicious, right, Dr. Evil. There might be good reasons not to do this. And so I think we need to look at intent when we're talking about ethics and in the law, right? This is why we distinguish between homicide and involuntary manslaughter. So their intent is not to do this. Also, and now I might be wrong, since I heard the conversation earlier, testicular tissue cryo, I thought was experimental. Okay, from the previous conversations. So, this is not a guarantee. Thank you, Emily, for the nod there. And so because it's not a guarantee, we may have less ethical obligation to do this because we can't, ensure that he will be able to have genetic children. Okay, but some say adoption for cancer patients can be really challenging, right? And so maybe we have more of an ethical obligation then to preserve his fertility because he may not be able to adopt down the road. There are all sorts of barriers in place, and Teresa and others have done this research. The other thing that comes into play with FP is hope, right? This is a really difficult time for Ben and his family. They want something positive to cling to. And so we see that for many cancer patients, that fertility preservation gives them this hope. And that's really important when we're talking about quality of life again, right? And that this is a quality of life consideration. Okay, but there are some concerns. So you're probably familiar with all these. Physical, right? Any procedure is going to have some physical concerns, any procedure that we do. Rare, but still a possibility. Psychological. This is a 4-year-old kid who's been through a lot. And so is this just one more thing? Is this going to add stress not only to Ben, but his parents? They've been through a lot too. This is also an experimental procedure. And so we don't know if it's going to work, as we talked about. Also, there's a concern about false hope. This is common to all experimental procedures, but sometimes people don't understand what it means to be an experimental procedure, and they think it's a guarantee. And so we have to be very clear when we talk to them that this isn't. So there's the concern about false hope. There also may be a conflict of interest. So if the clinician treating Ben is also running the study on testicular tissue cryo, there could be a potential or perceived conflict of interest. And again, I don't think people are malicious, like, oh, we're going to do this, and abuse the system. But it can happen. The other thing we need to look at when we're talking about all these pediatric cases is what is the parent's role here, and what influence do they have? So it's important to point out that this tissue belongs to Ben. This is his genetic material, right? So it is his. His parents are guarding it until he turns 18. So if he dies, this material needs to be destroyed or donated to research. It cannot be used to have a genetic child. And ASRM and ESHRA are pretty clear about this. And there is some debate on some of these topics, but there's the idea that in order to have a child with someone posthumously, you need to have a joint reproductive project. And typically, we have this heteronormative nuclear family model where it's 2 partners that do this together. But other people push back on that, and other cultures say, no, a multi-generational model may be appropriate. As of now, that's pretty much seen as unethical to use Ben's genetic material to have a child posthumously. Okay, so that's pretty much the consensus. Whoops, wait, wrong button, there we go. There's another concern that by using FP, we're telling him, we expect you to have genetic children. That we're setting up some sort of expectation for him, and he may feel pressured. They did this procedure, they paid all this money, and now we're saying, all right, clock is ticking, when are my grandbabies coming along? But I want to point out that this is not unique to FP, right? Parents spend all sorts of money on all sorts of things. Violin lessons, soccer practice, right? They expect, my parents may have thought I would have been the next Megan Rapinoe. Didn't work out. But they give money to this. College funds, pre-tax dollars, right? 529s, and then the kid says, nope, not going to college. So this is not, again, unique to FP. Parents do this all the time. Okay, one of the things that we need to talk about when we're talking about prognosis is what are his chances here? And we have to have a really clear conversation about this. And this is somewhat unique compared to the other 2 cases that we're talking about here. And when is the prognosis too poor to offer FP? And I want to give a shout out to my student, Jen Nanny, who's doing a poster on this, and she just graduated with her master's in bioethics. But she's addressing this exact issue, right? When is it too bad to offer this? And I think we need to make a distinction here between discussing it and offering it. And we always have to discuss it. Just like we would say, the treatment may cause nausea or hair loss or infertility, all these things, right? We can't pretend it doesn't happen. But do we need to provide it? That's a different question. And we heard a discussion earlier about conscientious objection. And providers are sometimes, are allowed to conscientiously object, or if they think something is not medically appropriate, to say, no, Lisa, I'm not going to chop off your right arm just because you want it chopped off, right? So there are, an example that happens all the time to clinicians, I want antibiotics for my common cold, right? Clinicians don't need to provide that. But where is that line between medical values and personal values when it comes to prognosis and what is medically appropriate for a very sick small child? I don't have a good answer for you. I know I'm supposed to have all the answers, but I don't. And what I tell my students, and it drives them nuts, is if you walk away with more questions than answers, I've done my job. You've gained Socratic wisdom, knowledge of what you don't know. They do not like that at all. But I think we really need to think about, in this case, I don't have a very clear-cut answer. And obviously, I don't have time to address all the ethical considerations with each of these cases, so I'm just highlighting some of the unique ones and some of the pertinent ones. Okay, finances, of course, comes into play, as well as we've seen. If he's involved in a clinical trial, it may be covered, so that may not be an issue. But fertility preservation is not always covered by insurance. We see that I think it's up to 17 states now require some sort of coverage for assisted reproductive technologies, but it varies. And we've made great strides, Teresa's made great strides, and others, to get coverage for cancer patients, but it doesn't always work out, right? So that is something to consider. So moving forward in this case, again, I don't have the answer. I think we really need to look at what is the risk of infertility for him and what is his prognosis. And I kept this intentionally vague, so there could be some wiggle room here. But if the risk of infertility is really small and the risk of doing a surgical procedure is really high, then maybe we don't do it, right? So we need to think about that some more. We also need to untangle Ben's interests from his parents. So imagine I told you that his parents are in their 40s, they went through a dozen cycles of IVF to get Ben, they really wanted a large family. You might be really sympathetic to them, right? And say, this is really tragic. But there is some worry sometimes in these cases, especially posthumous reproductive cases, that people are grieving, and that's why they do this. So what we see with posthumous reproduction is well, not lots, but many people retrieve gametes, but very few people actually use them. And what they realize is they were just grieving and they wanted to cling on to their loved one in some way. So we need to make sure we're teasing apart what are Ben's interests versus his parents' interests. Now I'm going to totally contradict myself. We also need to recognize that they're a family unit, right? And often, it's not just the person in the bed who's our patient, it's the whole family. And this is especially the case for pediatric patients because he doesn't have capacity to make decisions, right? And his parents know him best and may know his values best. So we need to recognize that they're all suffering and dealing with this together. So I know that's a fine line to walk and a little confusing, but I know that you all can do it. Okay, case 2. So let's do a DSD case. We have Zoli here, she's 13. She just began menarche, she has Turner's. We were just talking about Turner's, which is great. So diminished fertility. And FP is gonna be more likely to be successful at a younger age. And we can do egg freezing or ovarian tissue cryo. So we can talk about some of that later too. Her parents want FP, and they're pushing for it. And we can imagine they have all sorts of reasons for this. But Zoli is saying, I'm not convinced by your reasons, sorry, not interested. So what do we do in this case? Well, we'll get to the question of who decides, but first I want to point out something that is somewhat unique to DSD cases, and this is gonadectomy. So I'm talking a little more broadly now, not just about Zoli's case, but DSD in general. And so it has historically been standard of care to do a gonadectomy because of concern about cancer risk, cancer of the gonads, right? And if the gonads are internal, then it can be hard to monitor them. So we say, let's just eliminate the risk entirely and remove them. And part of this has been justified by the idea that these gonads are not useful. They don't produce hormones in the traditional way. They're not going to lead to fertility. So there's no harm in removing them. We'll see that that's not necessarily the case. And some people say, let's kill 2 birds with 1 stone. If we're going to remove her gonads, we can also do fertility preservation at the same time. So it's a win-win. So that's the argument. But again, the tide is turning on this. There's been a shift. And people are saying we may have to think twice about this, at least in all cases. And so some medical reasons against this is that the DSD risk varies depending on what condition you have, the risk for cancer. Some have a really high risk and some have a low risk. So we can't treat this as one universal category. We need to look at the specifics, right? Surgery involves risks too, right? And we need to weigh what those are. Again, rare, but there are risks. And what we found is some adults with DSD say they prefer endogenous hormones, that they feel like those have been better for them. So we need to take their quality of life considerations into account when we're doing these procedures moving forward. There are also a bunch of ethical and psychosocial considerations. And one is that this is a violation of autonomy. We try not to do things to children that are going to be irreversible unless we know it's going to be really good for them, right? So if we have a child who has an appendicitis, we will remove that appendicitis, right, their appendix, because we know that's an irreversible change, but we think it's going to be good, right? Beneficence, we're trying to promote good. But some are concerned that this may be harmful and that we can't go back, right? And it has been a history of normalizing surgeries, some of which some folks say are not medically necessary. So as an example, if a child is born with a large clitoris, sometimes we've made it smaller to appear normal for girl genitalia. The clitoris is the only part of the body that's purely for pleasure, so I don't really see how it would be harmful to have a large clitoris, but at least not physically or sexually. But there is this concern about this, that why are we doing this surgery if we may reduce pleasure for people and there isn't a medical indication, right? So we need to recognize that. And the UN and WHO have come along and said, these are human rights violations. You are doing irreversible damage to these children's bodies without their consent. And so we need to take that into consideration. This is just this last week in my home state of New York, they were proposing that we should outlaw medically unnecessary DSD procedures. And there is some concern, though, then that what repercussions will this have for trans folks who are trying to get surgeries or DSD folks who want to get surgeries? Should the law regulate what doctors can do? That's a whole nother question. But so this is something to consider as well here. We also need to recognize that there can be damage to one's gendered identity if you remove gonads. And so think of the way we talk about gonads all the time, or maybe not you, but maybe teenagers do. People, they say things like, it takes balls to do that, right? And there's this idea that, you know, having testicles gives you courage and manliness and strength and all these sorts of things. And so if you then remove them, what does that do to someone's identity, gendered identity? I've been hearing more and more, it takes ovaries. I'm trying to spread that. It's not really working, so I'm counting on all of you to help me with that. But what we see is that even for cis women who have had an oophorectomy or at least partial, there's this interesting hormonal hierarchy that happens, that the more of their ovaries they retain, the more womanly they feel. So the woman who has 1.5 feels like more of a woman than the woman who has 1. And the woman who has 1 feels like more of a woman than the woman who has half of an ovary. And so even though ovaries are not visible, right? It's not like you can see someone's ovaries from the outside, they still play a role in our gendered identity. So we need to acknowledge that as well. Okay, another concern that comes up for DSD that sometimes also comes up for cancer is this idea that you may be passing along your condition to your future children, okay? And there's this sense that we have an obligation to minimize harm and promote good for our future children. And there is a list so long for pregnant folks on what to eat and not eat, and all the good things you're not allowed to have. Prenatal vitamins, now you're supposed to be taking prenatal vitamins basically forever, whenever you think you might be pre-pregnant, which I guess is when you start menarche. So, you know, it's like it goes on and on. And the one that drives me, I think, the most nuts is the alcohol warnings that they say, you know, may cause harm to the fetus, which I understand, but it never says on there, may also cause you to be a jerk, right? I feel like that happens way more often, and we don't put that on there. I think bars should put that. May cause fights and all sorts of idiotic behavior. And so, but this shows you what a pronatalist society we are, right? That the one warning we put on alcohol has to do with fetuses and protecting them, not on all the other horrible things that people do when they're drinking, right? Like drunk driving and all these other things, violence. So we have this societal norm to prevent harm to our offspring. Some take it a step further, and I don't know if you can read this in the back. It's a window, and this like hippie couple are there. And they're saying, do we want a tech tycoon or a tax lawyer? And there's all these little babies in the window with their labels and what they're going to be when they grow up. But some take it this step further and say, we have an obligation to have the best child possible. And so we need to do whatever we can to do that. And some say, yeah, then CRISPR, or we get a Gattaca society, which if you haven't seen that movie, please do. It still holds up 20 years later. So good. But this idea that we're going to have designer babies, right? That seems to be taking it a little farther. But when we're talking about these issues, people say, if we have an obligation not to cause harm, then should we knowingly bring a DSD baby into the world? Is that causing harm? And what people say is that, well, let's talk about this. Some of the DSD conditions can be treated medically. So maybe it's not a harm to bring a child into the world who has a DSD condition, right? Also, if you're very concerned about this and you have a lot of money, you can do PGD. So you can test the embryos to make sure that you don't pass this condition along to your children. But then some of the disability activists and advocates come back and say, but wait a second, you're saying that DSD lives are not good? They're not as valuable as other types of lives? And so there's this disability perspective that we have to take into account. And a lot of DSD folks say, I'm not disabled, why are you calling me that? And we see this with various communities. The deaf community, Asperger's, Aspies, many of those folks say, I'm normal. I don't know why you're calling me disabled. And so who gets to decide what counts as disability? And folks with DSD are hesitant to put this label on themselves, many of them at least. Okay, so who decides? Here again, we have this question of paternalistic beneficence versus Zoli's reproductive autonomy. And I love this picture. I don't know if you can see she's rolling her eyes. Like, my parents have great stories to tell about I was a great eye roller. I haven't been practicing as much lately, but I still got it. But this is very classic, 13-year-old child rolling her eyes at her parents. And this case is a little more complicated. She's 13, right? She's not 4. And so there are lots of reasons to include Zoli, and I think we need to. She can't consent, but she can assent, right? She's old enough to be able to be involved. In a sense, that's a lower bar, but she can participate and give her input. Also, we need to look at the type of treatment being offered here. And as the treatment becomes more subjective, she should have more involvement. So imagine that this blue is the appendectomy I talked about earlier, right? 13-year-old says, nope, I feel emotionally connected to my appendix. I really want you to keep it in there. We're gonna say, no, we're getting it out, okay? We'll put it in a jar and you can put it on the mantle. But we're gonna override her, right? That's not a very subjective decision. That is a clear-cut, we will save your life or you will die situation. But as we move up here and things become more subjective, I think we need to involve children more. Reproduction is deeply personal, right? And so her parents may not know exactly what her reproductive wishes are, and she may not, frankly, either, as we'll talk about, but I think we need to get her input because this is such a subjective decision. It's not clear-cut. So yes, like I said, deeply personal. Okay, so there are some concerns with her being involved, right? I don't know if you can see this tiny little one here. This is the teenage brain. Memory for chores and homework. It's like the smallest part of the brain. There's some other really interesting ones too. The judgment gland, also very small. But her brain is developing. She's 13. It's not fully matured yet. So we might say, does she really have the ability to make these decisions? It gets tough. There has been some precedent where we have allowed children at age 13 to make certain medical decisions for themselves against their parents' wishes. That can be a side conversation we can talk about later. But let's cash out what some of those concerns are more specifically. So she might be refusing because she's scared, right? A transvaginal ultrasound is not really fun for anyone, let alone a 13-year-old girl who may never have been sexually active, right? So there might be fear, it might be discomfort, it might be all these things, whereas an adult may be able to weigh these more rationally. She may not be able to do that at her age. She also may not be able to predict her future wishes here. I had no idea at 13 that I would become a philosopher. I don't even think I knew what a philosopher was at 13, right? So we don't necessarily know what we'll want as adults. We may have a sense of it. It may change, right? So she may not know. And she also may not recognize the significance of genetic parenthood, right? Many teenagers are really focused on not getting pregnant, right? They're not as concerned with getting pregnant. And so this might be something that's just not on her mind at all, so she can't really incorporate how it may affect her down the line. Okay, so I'm gonna throw a little jargony ethics term at you of negative rights, because I think it's really important in this case here. And this is the right to bodily integrity. So I can walk around this room and I can do all my karate moves and my kicking and punching, but my right, which is not very good as you can see, but my right to do that stops where your nose begins, because you have the negative right to bodily autonomy, right? So I can't just punch you in the face because I feel like it. We all have this negative right to be left alone to make decisions about our body without interference. This is almost absolute in medicine. There are a few exceptions. For example, if you have a deadly and infectious disease like Ebola, then yes, we are going to quarantine you against your wishes. But for the most part, patients have the right to say, nope, sorry, don't want that. Even if it means they're going to die, right? They can say, nope, not interested. So if they have decision-making capacity, we allow them to do that. It causes a lot of moral distress, right? But we allow them to do that. So in her case, she doesn't quite have capacity, so that makes it a little difficult. Also, the logistics of forcing her, are we going to sedate her for 2 weeks while we hyperstimulate her? That does not sound like the ethics committee would come back and say, yes, great idea, let's do that. We actually had a case similar to this not that long ago. For different reasons, they wanted to sedate a child for a week. And ethics was thinking, it might not be the best. But logistically, how can we do this, right? Are the anesthesia folks going to be on board with this? This could be really traumatic for her to be forced to do this against her will. It might cause her to resent her parents, in the medical establishment, right? So not only are there ethical reasons, but logistically, how are we going to make this happen? Seems like it could be really complicated and difficult, and also cause lots of moral distress. Okay, so moving forward, in this case, I think there is more of an answer here. I think we need more conversations. So when a teen says, nope, not interested, we don't say, okay, great, let's move on, right? We come back and we have more conversations with her. But ultimately, if she still refuses, ethically, I don't know if we have a lot of ground to force her against her wishes. And there are a few reasons for this. One is it's a non-life-saving treatment, right? And usually courts intervene when it is a life-saving treatment. If parents are saying, nope, don't want my kid to get this life-saving chemo, the court says, nope, this is an imminent threat. We are going to intervene and override the parents' wishes. They don't intervene for things like vaccination, which is a whole nother ethical debate, but that's in part because that doesn't seem like it's imminent. It's not going to happen right now. So I think courts, and hopefully there's some lawyers in the room that can help steer us, would be hesitant to force her against her wishes here. The other is that she may have potential for future FP. She's 13 years old. Her fertility is going down, but she may still have some opportunities. Also, there's alternative family building. And unlike Ben, I don't know of any widespread discrimination against intersex folks of adopting. There is against trans folks and other queer folks, depending on how you define that. We'll talk about that in a minute. But I haven't seen any headlines denying folks because they have DSD. Maybe others have, and I'd be really interested to hear that if that's the case. So for these reasons, I'm hesitant to say we force her against her wishes. Okay, how are we doing with time? Good. I want to make sure we have time to actually talk, because I think ethics is not as fun when I'm up here like sage on the stage, just talking head, right? Okay, so trans fertility. So here's our next case. We have Jackie. Jackie is 16 years old, assigned male at birth, but identifies as female, has been on puberty blockers since age 9, and now is super eager to start hormone. And Courtney did a nice job talking about trans issues earlier on, so she wants to start hormones like you might expect. It's really hard for gender dysphoria to not, for all the reasons that we know, and also to not have hit puberty when all of your peers have, right? Middle school, high school is an awkward time already. So Jackie's really eager to get started. So some of the contextual features here that we've been talking about, she's interested in FP. She wants to do this. And she currently identifies or is attracted to people who identify as female. And she wants to be able to have a genetic child with a future partner. So if she is attracted to a cisgender woman, that woman can bring the egg, and Jackie can bring sperm, and they can have a baby together. They need to get the oven from somewhere. They can figure out whose oven. But I think this can happen, right? Sometimes I hear folks say, well, depending on their sexual orientation, we shouldn't allow FP if their gametes can't mix in the way to form an embryo. I don't think that makes any sense because there's all sorts of ways to build families. So I just want to throw that one out the window off the get-go. All right, so Jackie's parents here. Jackie's parents, Jane and John, this is going to be like a tongue twister. They're divorced. Jackie lives with Jane, but they pretty much share custody. Jane is in support of Jackie's choices. Jane says, yes, let's get you started on hormones. Let's do FP. I'm totally on board. John says, I'm not so sure. John has some concerns about Jackie going on hormones because there can be irreversible side effects, and he doesn't know if the science is quite there. He's not really sure about what it means to be trans. He's not fully supportive, okay? And he says, FP, total waste of money. Why are we even bothering with this? All right, so those are the background features here. So who decides here? Dun, dun, dun. Well, Jackie may be able to give consent. She's 16 years old, right? We sometimes allow 16-year-olds to give consent. Legally, it can get tricky because age of majority is 18, so it depends on how we maneuver this. But she may be able to give consent. And she should definitely be involved in these decisions. It seems hypocritical to involve her in gender-affirming care and not FP, so I think we should definitely involve her in both, because both are very subjective decisions, right? This is not, do we give you drugs to cure strep throat? This is something very personal, so I think they both need to be involved. But there are some legal and logistical barriers for her to get access to FP that we'll talk about. Okay, so now I introduced negative rights. Positive rights are the opposite. This is the right to something, okay? And this means that others have a duty to provide it. So for example, in the US, we all have a right to K through 12 education, and someone has to provide it, it's the government. Doesn't say anything about the quality of the education. We all get an education, right? And so positive rights in medicine means being able to say, I want this treatment. But it's limited, right? I can't come in and say, all right, here's my laundry list, I'd like all these things, and the physician has to say, yes, let me sign off on that, right? Physicians also, and healthcare providers also have autonomy to say, no, I don't want to do that. And so positive rights are limited. And this makes it difficult for people to be able to get access. So there are wonderful organizations like these that are helping people get access, but there isn't a positive right to reproduction in this country for anyone, right? We don't cover assisted reproductive technologies or any of these things for anyone. Israel is a case where they do, right? They give you the technologies or whatever you need to have babies. We don't do that. We have a negative right in this country not to have children if we want to, right? And maybe it's on shaky ground, but we do have a negative right to use contraception, to get an abortion, all these sorts of things. But we don't have a positive right to say, government, help me make a baby, okay? So parental consent is also a barrier. In many cases, children have to get their parents to sign off on their ability to go on hormones and to get FP. So if her parents are not signing off on this, it may be really hard for her to get access to this. So there's that barrier. And some say this doesn't make sense because we allow minors to get other types of treatment without parental consent, right? So if we're gonna make an argument by analogy, we allow this. This is the same thing. Why don't we allow this? So minors can go to Planned Parenthood or wherever and get all sorts of reproductive services. Again, abortion is an exception. In some states, there's a parental notification requirement. But there are other types of procedures that minors can get without parental consent, like substance abuse disorder, right? Treatment for that, for mental health conditions. They can get these sorts of treatment without their parents for a host of reasons. One is public health reasons, right? We want kids to go in and get treatment for STIs so that they don't share gonorrhea with the whole school. So similarly, you know, we have these public health reasons for allowing this. There's also, we recognize these are stigmatized conditions often, and we realize that kids may not go in and get treatment for it with their parents knowing. So we want to give them an option to go around their parents' back. But we also recognize many of these things, mental health, substance use, reproduction, sexuality, as being deeply personal. And so we want to allow them to make their own decisions. So is it then fair that we don't allow children to make decisions about FP, right? So how are these different? I'd love to hear people's thoughts on that. And even if she did have the ability to do this, there isn't a, Planned Parenthoods are somewhat common, maybe going away a little more. But she may not know where to go, right? Kids have heard of Planned Parenthood. Most people, children, I assume, haven't heard of the Oncofertility Consortium, although Teresa's changing that. So maybe they all know, and they'll say, I'm going to go to my local fertility clinic and get this done. But there's a knowledge gap that might be there as well. Okay, cost we've talked about as a barrier. It's expensive, and it's not covered by insurance always, right? This is a lot of money. And so it's important to point out that even parents who are supportive, even if Jane and John both are saying, yes, we definitely want to do this, they may not be able to afford it, right? Again, there's not a positive right to reproduction. And as far as I'm aware, there aren't charity programs for transgender FP. If people know of ones, please let me know, because the ones I listed before mainly have to do with cancer. So that's also a barrier. So there are some paths for Jackie toward genetic parenthood, and I want to lay some of them out and talk about the pros and cons here a little bit. She can delay hormones until she's 18, and then at age 18, she can make her own decisions. But that comes with a real psychosocial cost, right? She's already 16 and hasn't gone through puberty. It's going to be really challenging to wait another 2 years in high school, right? So that one may not be super attractive to her. She could seek emancipated minor status. Legally, that could be challenging. That could cause a rift with her family. There's all sorts of other concerns for that as well. She could go off hormone therapy and then try to have a genetic child as an adult. And that was talked about as well this morning. And there have been some successes, but it's not a guarantee. And we don't know how the hormones will affect her future fertility. So it raises that concern as well. There is alternative family building, as was mentioned. But again, expensive, right? And for all the other past genetic parenthood I just had, cost is always a barrier again, unfortunately. And then there's all these are just from last week, headlines about LGBTQ folks being denied adoption. And so there may be real barriers for Jackie to foster or adopt children because of some of these policies. All right, so how do we move forward in this case? So I think providers want to be supportive of Jackie, ideally just like they want to be for all of their patients. But it's a little tricky because do you encourage Jackie to get this done behind your parents' back, right, over John's objection? That may put the provider in an awkward position. Jackie's a minor. She needs her parents' financial support, and she may need their parental consent as well. So we don't want to put the provider in this awkward in-between place, right, as the middle person. Ideally, we'd like to uphold Jackie's wishes, but it may not be possible because of some of the barriers we talked about. So there are some legal solutions possibly for moving forward. Mediation, maybe that could lead to some sort of resolution. A neutral third party could perhaps help out. We could also look to the divorce agreement and see what that says. So Jane may have ultimate legal decision-making for Jackie, depending on what their divorce agreement said. So she may be able to say, sorry, John, too bad, I'm making these decisions. Or Jane can appeal for final decision-making on Jackie's behalf. And what we have seen is that sometimes the custodial parent has been able to have final decision-making authority. So these are some options for moving forward. I want to make sure that we have time for questions, so I am wrapping it up now. So I haven't covered everything, obviously. We'd be here for years. But we did cover some of the main issues here. I really enjoy all the collaboration that happens in this environment. I want to welcome it more. So if you're ever interested in these types of projects and you want to work on it and you want to consult your local philosopher, you can reach out to me. I just joined Twitter like a week ago. I have no idea what I'm doing, but I figured maybe I'd put my handle up there. So thank you so much, and I welcome your feedback.